Thanks very much, Neil. It's an honor to be here and to talk to you today about a topic that's really become increasingly important in the management of prostate cancer, and that's how we use molecular markers to help make the right treatment decisions. So, the title's a little different, but the talk is essentially the same. So I've actually worked with a number of the companies in this area. I have had research funding from Myriad. We're going to be talking briefly about Polaris, as well as Genome DX. I've had a research collaboration with them and have given one talk at a CME meeting specific to them. So we're going to go through and kind of take a little bit of a different approach. We will go through the tests and kind of their relevance, but I want to take a step back and really say, what are we trying to do here? And we're really trying to get to the holy grail, which is personalized medicine. And we hear this a lot in terms of genetic testing of the tumor to try and advance the right therapy for advanced stage cancer. But essentially, that's what we're trying to do here. So I want to kind of give a different view of what is personalized medicine, what is genetics, and kind of go through, for those of you who may not necessarily remember all the molecular biology you learned back in undergrad or medical school, just kind of what is genetics, and then again going through the three tests that we have. I'm not sure it's specifically geared towards, in terms of active surveillance, the discussion, because I'm not sure that's actually the best use of the test. I'll kind of go through my thoughts as to where we should be using these tests, and then we'll conclude. So personalized testing allows the right patient to receive the right treatment at the right time. That is the goal of personalized medicine. So when we think in terms of prostate cancer, men with aggressive disease would receive aggressive therapy. Multimodal, it's radiation plus ADT plus chemo, surgery with adjuvant radiation and chemo thrown in there, maybe immunotherapy, the whole gamut. Whereas those with less aggressive disease can be managed expectantly. And if we do this right, we will reduce side effects and improve outcomes. So not just trying to reduce side effects, which we hear a lot about, but there's a lot of men with bad disease that are undertreated. So it actually, ideally, will accomplish both goals. So currently, we do this, and we've been doing this for a long time, as we've heard nicely in terms of the value of PSA. There's some newer tests, which I think are marginal step forwards. Hopefully genomics is going to be the leap forward. But we've been doing this for a long time with PSA, stage, and grade. That's our classic prostate cancer triad. And we break patients historically into low, intermediate, and high risk. We now have very low, favorable intermediate, unfavorable intermediate, high risk, very high risk. But the concepts are the same. This is based upon PSA, stage, and grade. And there are multivariable models we can use, Parton tables, Capra, Catan nomogram, Stevenson, and many others. And they all have some value. And they're all good at what they do. And they can predict outcome, whether it be recurrence, upgrading, metastasis, prostate cancer death, but they're not perfect. A lot of these, and when we look at accuracy, a lot of them will grade them using an AUC, an area under the curve. So 1 is perfect accuracy. 0.5 you would think is 50% right, but a flip of a coin is 50% right. So 0.5 is basically a flip of a coin. It has no value. Most of these will sit somewhere in the 0.7 range. Occasionally you can get a study where it's into the 0.8 range, but there's still a fair amount of room for us to get better. So this is what we're currently doing. We're trying to read the tiles, but it's fuzzy. We're having a hard time. And so the goal is that patients walk in the door with cancer, and we put it through some molecular prism, and we can actually sort out whether it's a red cancer, it's a yellow cancer, it's a blue cancer, and then we'll be able to target the specific intervention. And currently our early stage interventions are surgery or radiation of various forms. We have HIFU some now, but they're not necessarily molecular targeted therapies. We're moving there though. ARV7 for advanced prostate cancer, DNA repair defects, and you think about PARP inhibitors. We're moving in that direction, and we're going to see it even for earlier stage disease. So what is genetics and genomics? When in doubt, I always go to my favorite source. I look it up in Wikipedia. So genomics refers to the study of the genome, which wasn't that helpful to me. So I had to go to figure out what a genome was, which is the genetic material of an organism. So in common sense, in common terms, genomics is basically analysis of the DNA. That's what makes us unique, separates us from other people, from monkeys, from bananas. It's all in the DNA. The genome is made up of 3 billion base pairs, of which everybody in this room differs by less than 1%. Very subtle differences. These differences, though, ultimately determine how we look, how we think, how we act. And importantly, these differences can affect the tumor growth, as well as you actually get additional DNA changes within the tumor. So not just the tumor is what you are, but it develops new changes. And traditionally, we thought of DNA going to mRNA, going to protein. But now, it's a whole lot more complex. DNA can go to microRNAs, can go to link RNAs, long, non-coding RNAs. Yes, it can still make mRNA, messenger RNA, which they can go to protein, or they can actually act on other RNAs. They actually can go back and alter DNA function. It's a very complex world. And the reason I'm bringing this up is this is relevant for what I want to give a little bit of background here is not just, hey, Polaris is this test and this is what it does, but actually understanding some of the molecular biology underlying why some of the tests have the limitations they do, why I think some tests, in my opinion, it's opinion, are better than other tests because what they can tell us and ultimately what they're all telling us about the tumor. So how do we measure genetics? We use the polymerase chain reaction, PCR, to measure specific messenger RNAs. And generally, that's many of the tests that we have available do that. And the problem with that is you're limited by a small number of genes you're looking at. So some of the tests we'll see, they measure 30 genes, they measure 20 genes. It's a very small number of very specific genes. So a different way of doing it is using a gene expression chip, where you take your RNA, you put it on a little chip. The chip can have thousands, millions of little specks, little dots. Each one of them is one RNA. You add the RNA, you wash it, and wherever it's bound, that means that gene was present, it's turned on. And that's what we'll see some of the tests out there use that. And that can give us a lot more information than just the 20 genes. You can now do RNA-seq, which we are doing more and more, certainly in the laboratory. It's basically you just sequence all the RNA. And the beauty of that is it's going to tell you is if there one little base pair change in one RNA, which says this gene is now making this amino acid rather than this one, which means even though the gene is present, it's non-functional. It's not going to work. So we're learning that, and that's how we're starting to sample tumors now in patients in the clinic. You can also do whole exome RNA, which is basically just the transcribed RNA. You can do SNP chips, which are small nuclear polymorphisms. Again, those are the little base differences that separate each of us from each other. And this can either be done one at a time, or again, there are chips to do a large number of these. We can also look at copy number alterations or variations. We know certain genes get amplified. Androgen receptor is a classic one in terms of advanced prostate cancer. That's one of the mechanisms that actually leads to castration resistance, overexpression of the androgen receptor. We can now measure that. And you have whole regions of chromosomes that get amplified. MYC is a common area, c-MYC, that's amplified. You get loss of other things. And those actually can be used to predict not only outcome of the patient, but what is the biology of the tumor. In the future, is going to help us direct what is the right therapy. And then ultimately is the whole genome sequencing. That's the whole Human Genome Project. Cost billions to sequence the first one. We're now getting it cheaper and cheaper. It's down to, in some cases, can be done as low as $1,000 to now sequence someone's genome. The question comes up of how many X you want to do the sequencing in, i.e. how deep do you want to get it. If you just do a lot of our DNA as repeat sequences, so if you do a light sequencing, you're going to get the most common areas, but some rare areas you may not be able to sequence until you get many fold number of sequences in, and there your cost going up. So based upon cost and the way things are done, using PCR generally is the most common test out there. It tends to be the cheapest test out there, but it's missing an opportunity to really learn about the tumor beyond those 20, 30 specific genes. So in terms of reviewing the molecular test out there, we've heard a wonderful talk in terms of the value of who to biopsy, in terms of PSA, 4-core, 4K score, Phi. There's also another one called Epiphany. I'm not going to talk about it. I do have a conflict of interest with them. I've been working with them. But it's actually the only non-PSA based assay out there. I'm happy to take questions at the end if there are any related to that, but it's not going to be the focus today. In terms of when to rebiopsy, there's the Confirm MDX, PCA3. And then where we're going to focus today is who to treat in terms of Decipher, the Oncotype DX and the Polaris, and then how to follow patients after therapy who've had surgery in particular, where we actually have the whole prostate in hand, we have the whole tumor in hand, and we can be very accurate with our molecular tests. What information can we gain from there? So that's what we're going to focus on the right-hand side of the slide. So Polaris uses formalin-fixed, paraffin-embedded tissue, and the concept is cells that are growing very fast have to cycle through the S phase. And as you remember, it goes from G0, you move in G1, you go to G2, you replicate your DNA, you go through this S phase, and you kind of keep that going. And there's certain genes that you need to go through the cell cycle. Most cells in our body are just sitting there, they're not replicating. Tumor cells replicate faster, bad tumors replicate even faster. So if you measure the expression of genes involved in going through the cell cycle, higher expression means a faster growing tumor. Faster growing tumor means more aggressive tumor. So that's the concept behind Polaris. It's focused on genes involved in the cell cycle, and they'll often call it CCP, the cell cycle progression score, CCP score. They use 15 housekeeping genes, which is basically 15 genes that don't change regardless of how fast the tumor is growing, how slow it's growing, if it's not growing at all, to kind of just make sure they have the right number of RNA in their analysis. So it was originally developed in men treated conservatively. So actually had a very interesting cohort that they looked at, was basically men diagnosed by Terps in England in the pre-PSA era. So generally by Terp, what I mean is not necessarily done for BPH in terms of men with very large prostates, urinary symptoms. We do the Terp and there's a tiny few specks of cancer. These were often men who had Terps done for more locally advanced prostate cancer. Didn't have surgery, didn't have radiation, had hormones when appropriate, and it showed it was a very strong predictor of who lived and died from cancer. So, and now has been replicated in many different studies in both prostatectomy specimens as well as biopsy to predict outcomes, really whether you're undergoing active surveillance, whether you're undergoing surgery, undergoing radiation. And so it's a really robust, it's probably, I would have said, certainly a year and a half ago, I would have said it was the most published on test. I'm not sure that's necessarily the case today. I think Decipher may have more publications, but it's certainly been very well published that higher scores do predict more aggressive cancer. Again, it can be used after radical prostatectomy, and the question is, and there's no easy answer, and this is where the challenge comes in, is what is the threshold in which you should say, aha, this is high enough, this is a guy I'm not comfortable doing active surveillance. And the challenge with this, and I'll put in kind of my philosophy here, is I think about these, when you look at all these tests, any molecular test, PSA, anything, they're all what I call multipliers. And what that means is, on a statistical sense, you take everything you know about the patient, and you try and make a guess at how bad their cancer is. And let's say I think the risk of this patient of dying of cancer, if I put him on surveillance, is 1%. Let's say I think that's his risk of dying based upon his PSA, he has one microfocus core of Gleason 6, everything I can put together about him, negative MRI. And then I do a genetic test. Those genetic tests, most of them in the range of maybe 3, maybe 5-fold, maybe multiplier. Meaning I take my 1%, and I can go up to 3 times that number, or I can go down by 3 times that number. So if I think, based upon his genetic test, he has really bad disease, it means it's 3 times worse than what I thought it was clinically, which means instead of his risk of dying of prostate cancer being 1%, it's 3%. In which case I'll probably say, who cares? That's still pretty low. Now if it's 0.3, maybe I feel a little bit better. But so a patient that's really, really low risk, there's really not a place to focus in, I think, on molecular markers. And we're actually, interestingly, I don't want to say too much, but the AUA guideline panel is reviewing for clinically localized prostate cancer. And it's going to be coming out in a couple months, and I think there's going to be some statements about, I'm actually on the guideline panel, so that's why I'm not allowed to say too much. There's going to be some guideline statements about the use of molecular markers, and I think it's going to be in line kind of with my thinking, not that I drove the panel at all, but for the really, really very low-risk patients, I don't think there's a value for molecular markers, period, in general. Now, if I'm not sure, and I say, look, I think his risk of dying of prostate cancer left on active surveillance 10, 15 years down the road is 10%. And I have a molecular marker that can tell me, no, it's 3% or it's 30%. That's going to make a huge difference. If it's 3%, okay, he looks like he's a little bit worrisome. Maybe he's a high volume 6, low volume 7, 1 core. I'm not sure, but the marker says he's low risk. Great. I'm feeling good at that point. If it says it's high risk, I'm really worried. So I think we need to be using markers in men where we really don't know what the right answer is. For the very low risk patients, we know what the answer is. For Gleason 8, 9, 10 disease, we know what the answer is. So I don't think the current molecular markers are going to help in those extremes. You can think about a traffic light analogy. Green light, you're good, active surveillance, great. Red light, dangerous, we need to rush to treatment. Yellow, somewhere in the middle, we need to stop and think about it. That's where we're going to find the value, the clinical utility of molecular markers. Oncotype DX, also known as GPS, is another formalin-fixed, paraffin-embedded tissue analysis. It's been done probably on the biopsy tissue, and it's based on 17 genes, so even fewer number of genes. But this time the genes come from multiple different biological pathways. So we get a little bit of insight. They don't really tell you which gene is up, which gene is down, so you don't really understand necessarily the biology of the tumor, but they do give you a score of is it more aggressive or less aggressive. And is developed for predicting risk of adverse pathology at the time of radical prostatectomy. So basically the idea of is this a patient a candidate for active surveillance or not? And in the first study you actually look at, you had to have a 15% higher, or 15% or higher risk of having Gleason 4 plus 3. Not just a little 3 plus 4, but 4 plus 3 for this to add any value. If you actually look at the decision curve analysis. So again, going back to that very low risk man, where we know it's not a 15% risk of 4 plus 3, their own study shows this added 0 value. And again, they included men with Gleason 7 in their initial development study. And for those men, I think molecular markers is a great test. Whether you have a little 3 plus 4, I'm not sure. So, and they've done one validation study. I think there might actually be a second now. And it did correlate with metastasis, but they only had 5 cases of metastasis. So we don't know if it correlates with prostate cancer death. I think it will. I don't think there's any reason to think that it won't, but it's not nearly been as well validated or well developed in terms of the publication track record compared to the other 2 tests. And then Decipher. And I'm going to spend a little bit more time on Decipher because it's different. And that's what I like about it, is that it is different. So it does use formalin-fixed paraffin-embedded tissue, and it does measure genetic material, similar to the other tests, but it actually uses a gene chip technology. And so rather than getting our 31 genes or our 17 genes, that actually gets 1.4 million genes. So we don't have that many genes, but we have different alternative splices. You have things that are long non-coding RNAs, you have microRNAs. All of those are captured by the Genome DX platform. So ultimately from that, they do distill it to a 22-gene Decipher score. And at first I'm going to focus on the score, but then tell you kind of some of the stuff that we can do with the Genome DX platform. Again, keeping in mind that there's 1.4 million more data points than just the Decipher score. So initially developed on men undergoing radical prostatectomy, and it did predict the risk of metastatic disease. And it outperformed all of the other markers, PSA, stage, grade. And actually, when you looked at Decipher score, if you knew the Decipher score, your PSA, stage, and grade didn't add any information. That actually told you everything you need to know. It's hard to believe. I understand the statistics. I've worked with them. I've seen it in my own data. But it's just hard to imagine by knowing a genetic score, I don't need to know someone's PSA or their grade or their stage or anything else about them. But that's what the data suggested. They came up with 3 different cut points, low, intermediate, and high risk. And you see, in terms of now here, this is a study that we had published for men undergoing salvage radiation therapy. And what you see here is based upon the Decipher score, we had a group where 10-year risk of metastasis was 5% and a group where it's 40%. Just by knowing the Decipher score, I could identify the risk of metastasis with quite dramatic differences. And this was all in the salvage radiation setting. So something that I think is really interesting is the question is, what do you do with this information? So I've done my genetic test. It tells me the patient is high risk. It tells me the patient is low risk. How am I supposed to use that information? That's the challenge that we have. We have good tests. We just don't know how to use them. So this is actually a very interesting study that actually asked, can we use this information to decide who and when to radiate patients after surgery? So this is 188 patients who had an indication for postoperative radiation, pathological T3 or positive margins. And the patients all received radiation at some point after the surgery. And the primary endpoint was the development of metastatic disease. And so the age-old debate is, do you do it adjuvantly right after surgery, or do you wait and see if they develop salvage, and I'm going to radiate them when their PSA starts to go up? And I think a lot of us in the room tend to, if you look at the numbers of practice patterns, we tend to err towards salvage. But there's probably some patients where adjuvant's the right answer. We're just not sure who that is and whatnot, so I think we're not sure. And this study actually helps us because they defined adjuvant as less than 0.2, but salvage as greater than 0.2. And what you see is if you had a low score, so your Decipher score is low, saying your risk of metastatic disease is low, whether you did it right away or waited, the risk of metastasis was low and no different. Basically saying for these low-risk patients, we probably can wait, safely wait. Some of them won't recur, gives them more time to develop continence, erectile function, whatever, get them to get over the shock of having surgery. But if you have a high Decipher score, huge difference here, huge difference here. And if we looked at adjuvant, maybe a suggestion for low risk, it helps a little bit, but not significant. But if you're high risk, doing an adjuvant, cut the risk of metastatic disease by 80%. 80%. It's a small study, it's retrospective, it's not randomized. Nonetheless, quite a significant difference here is saying if you have a high Decipher score, you should really be thinking more about adjuvant therapy. And so we are starting to incorporate this into our practice now of patients where we're thinking about adjuvant radiation, using Decipher to help decide, should I be doing adjuvant or should I wait and be doing salvage? Decipher has been shown on biopsy as well. It's a newer test. Some other companies will tell you, oh, it only works for post-prostatectomy, it's not available on biopsy. Well, that's not true. It is available on biopsy. There's not as robust publications on it, but it has been shown to correlate with metastatic risk as well as the score on prostatectomy, as well as, interestingly, radiation-treated patients. So for those patients that are never going to get a prostatectomy, we're never going to know the real genomics, if you will, of the tumor, this will work on the biopsy. Something, again, showing my own bias here, that I really like about the Genome DX platform is it gives you 1.4 million pieces of data. It's not just a Decipher score. So, and this has been now worked over, and they've created new tests, and tests that when you order it, they will give you the sensitivity to hormonal therapy, radiation, chemotherapy. They have a publication in terms of post-op radiation sensitivity, Porto study that was just published in Lancet Oncology. We're really learning actually a lot of what's coming out about prostate cancer biology and understanding in terms of classification, molecular classifications of prostate cancer coming out from this Genome DX platform. It's 10 times larger than the NCI repository in terms of prostate cancer genomics, 10,000 patients, and it's growing at a patient an hour. So I can tell you many of my academic colleagues are working with Genome DX. We are. I know the group at Hopkins has been doing it, the group in Michigan, UCSF. Many people I know are working with them, and in a matter of about a month with my involvement with them, we've had a publication, 2 in Journal of Clinical Oncology and 1 in JAMA Oncology coming out in just the past month in terms of the new information that we're learning. So I think Decipher is a great clinical test that can be used today. We actually get a lot more information, and we're going to continue to learn about prostate cancer biology. And again, it gives you much more detail in terms of the molecular subtypes, immuno-oncology signatures, invasion angiogenesis, a proliferation, a neuroendocrine signature. We get all of that from the Genome DX and the Decipher platform. So in summary, we are rapidly approaching the era of personalized medicine. We have new tests available, and we have new ones being developed constantly. There's many that we didn't get a chance to talk about. Urinary oncosomes is another one that's looking very promising. There's a lot out there, and they all work. We have our favorites. At the end of the day, I think they all work. I have tremendous bias towards the Decipher test, but I think they all work, and they're going to work better than just PSA, stage, and grade alone, again, in the right patient. And the key thing is, that final point is, it needs to be the right patient. We're spending a lot of our time doing genetic testing in patients where we already know the answer. And we're just afraid to do active surveillance for whatever reason. And that's changing. And that's a good thing that's changing. But we need to be comfortable with active surveillance for the very low risk, comfortable saying the high risk needs multimodality therapy, and focusing our energies on the intermediate risk where the genomic test really can impact the management and lead to those better outcomes, reduced side effects.